Hi, I'm Dr. Twaseem and welcome to my derm classes. Today's lecture is on different types of psoriasis. So I'll be dealing with different types of psoriasis, different types of nail psoriasis, as well as psoriatic arthritis. So let's get started. Delving into the classification of psoriasis. Psoriasis is mainly divided into chronic plaque psoriasis, guttate psoriasis, and the pustular variants, which mainly includes generalized pustular psoriasis, acrodermatitis continua of Hallerview, as well as pustulosis of palms and soles. We'll be dealing with in detail with each of these. The next classification is based on the site. So the psoriasis basically divides into the scalp psoriasis when there is involvement of scalp. Then we have the flexural psoriasis where there is involvement of the flexures. Then you have the sebo-psoriasis where there is involvement of the seborrheic sites. Then you have the genital psoriasis, oral mucosa involvement. Then you have the nail psoriasis as well as the follicular psoriasis where there is involvement of the hair follicle. So coming to the first clinical picture, here you can see that where there is a well-defined erythema with scaling and there are multiple plaques. So this is nothing but chronic plaque psoriasis, and the classical sites of involvement for classical chronic plaque psoriasis is basically elbows, knees, lumbosacral areas, hands and feet, and scalp. So make sure you check these areas when you see a lesion of psoriasis. And another thing is that you generally can look for what we call as auspit sign as a confirmatory sign. So here you take a glass slide and scrape off the superficial layers of scales, and what you can see is pinpoint bleeding. So this is not routinely done, but this is something that you can do in order to confirm psoriasis. That's called as auspit sign. And then there is possibility for complete remission in chronic plaque psoriasis. You can also assess the severity based on what we call as a PASI score, which is psoriasis area and severity index score. This is not generally done routinely in clinics because it's a bit time consuming, but it's done mostly in clinical studies. There can be involvement of genitalia in 45% of the cases. And if the number of psoriatic plaques are increasing, patients complaining of pain, and you can see some pustules, it might be that the psoriasis is going for an unstable phase. Once the psoriasis goes to an unstable phase, it can result in what we call as the erythroderma, where there'll be erythema and scaling in more than 80% of the case, 80% of the body surface area. So you just make sure to clinically look for all these signs. Coming to the next clinical scenario, here you can see that there is an erythematous papule with scaling. And so this is what we call as guttate psoriasis. So this is generally seen in children and adolescent age group, and generally there is a history of preceded infection with a streptococcal bacteria. So generally there will be an infection of throat pain or a URI. So this generally has a very good prognosis, generally resolves in response to treatment. Coming to the next clinical picture, here you can see that there is a diffuse erythema, there is scaling, and you can see pustules as well on the thighs. So this is a case of generalized pustular psoriasis. So the pustules that you see in generalized pustular psoriasis is basically sterile pustules. And generally the precipitating factors are pregnancy, tapering of corticosteroids, any application of irritants. It can be because of any infections or hypercalcemia. So make sure you ask in history in detail about these features. And then for postgraduates, there might be a differential diagnosis about autoinflammatory syndromes, where there is CUD14 mutation, DIRA mutation, DITRA mutation, etc. And coming to the different types of generalized pustular psoriasis, so you have the von Zumbusch type, where you have painful generalized pustules and erythema, as you saw on the previous picture. And then you have the annular pattern, where you have annular lesion with pustules that's arranged in an annular pattern with a central clearing. And then you might get an exanthemic pattern, where you have pustules that come and go on and off. And then you might also get a localized pattern, where you have pustules that appear at the edges of the plaques. So this is an example for annular pattern of pustular psoriasis. Coming to the next clinical picture, here you can see that it's a well-defined lesion in the palms and soles with a background erythema as well as pustules. You can also see some brown macules. So this is nothing but pustulosis of palms and soles, and it's generally seen after any infection or patient might be having an episode of stress or smoking. Coming to the next clinical scenario, so this is, again, you can see it's a picture of two thumbs, and there is a very well defined erythema and scaling, as well as there is pustules at the nail bed and the nail site. So this is what we call as acrodermatitis continua of Halepiu. You might also get shedding of nails in this case because of the intense inflammation, and you might also get associated annulus migrans of the tongue. Next, coming to the scalp psoriasis. So what you can see here is there is involvement of the hairline with erythema and the scales. So another close differential in this case is seborrheic dermatitis. So you will have to in detail examine the patient. You might also go for a dermoscopic examination, which might also help you to differentiate between seborrheic dermatitis and scalp psoriasis. Another differentials that you need to keep in mind is atopic dermatitis or tinea capitis. And a patient also might complain of hair loss if there is an intense inflammation, as in case of erythroderma, or due to any treatments that we take that's given for psoriasis. Coming to the flexural psoriasis, here you can see there is a very well-defined erythema in the flexural sites with a fissure. So generally this is seen in the flexural sites like retroauricular fold, intergluteal cleft, inguinal crease, axilla, and the inframammary region. So the older individuals with obesity also, it's very commonly seen. Coming to the next clinical scenario, here you can see there's a very well-defined plaque in the penis with erythema and scaling. So this is genital psoriasis. So this generally involves a scrotum. It can involve the penile shaft and the glans penis. And there can also be involvement of vulva in females, basically the labia majora. Coming to the oral mucosal involvement, here you can see that there might be geographic tongue, there might be fissured tongue as a part of psoriasis. There might also be migratory annulus erythematous lesions with hydrated scale. So these are the mucosal lesions in case of psoriasis. Coming to the nail psoriasis, in 10 to 80% of the psoriasis, you might get a nail involvement. So it's very important to know what are the different features of the nail involvement in psoriasis. So fingers are mostly involved rather than toes in psoriasis, and it's more likely that if the patient has nail involvement, the patient is more likely to get psoriatic arthritis. So the different nail involvement depends on which site of nail it involved. Is it nail bed? Is it nail matrix, etc. So if it is the proximal matrix of nail that's involved, you might generally get pits in the nails. As you can see in this image, you might get pits. If the mid portion is involved, you get leukonychia, where there is, as you know, where you will get white nails and loss of transparency. If the nail bed is involved, you will get what we call as oil drop or salmon patch. This is highly specific for psoriasis. So this is what you see in the last image in here, in the last finger, as you can see in the image. And if there is involvement of the distal nail bed, what you can see is subungual hyperkeratosis and distal onycholysis. So patient generally complains that they are not able to cut their nails properly. You might also get splinter hemorrhages at the nail bed. So you might need a capillaroscope or a dermoscope to view that. So coming to the psoriatic arthritis, as you can see, there are 5 different types of psoriatic arthritis. So it can be distal interphalangeal joint involvement. It can be oligoarthritis, where there is involvement of distal and proximal interphalangeal joints. It can be arthritis mutilans, which is a more severe form. It can be spondylitis-like, and it can be rheumatoid arthritis-like. As you can see in the first clinical image, it's involvement of the interphalangeal joints, which results in swelling. And there can also be associated what we call as dactylitis, which results in the fusiform swelling of the fingers. And the second picture is the severe form of psoriatic arthritis, which is arthritis mutilans. And this happens because due to the inflammation, there is also resorption of the bone. So that basically results in arthritis mutilans, which is the most severe form. So that's all about different types of psoriatic arthritis, and that again concludes my today's lecture. These are my references. Hope this lecture helped. Thank you so much for listening, and let me know in case you have any doubts.